myself, Dr. Nitin Kararia. I welcome you all to today's session of the NEET MDS 2025 recall session. In this session, I would be discussing about my subject, that is cons and the related dental materials that I have been taking. So I hope I am well connected. Both the audio and the visual are correct. So if I talk about the cons and endo section this time, it was relatively straightforward and simple, I would say, of the intermediate difficulty. Barring a few questions, majority of them were from directly from the notes or whatever have been taught to you in the class. So let us start with the recall discussion. Okay. Right. Few of them were from the first question is it is displayed, and I just want to remind you one thing, that majority of the questions compiled over here are from the recall basis, both the questions and the options. So definitely there would be certain discrepancies in the language. It may not be exactly what I have been asked in the exams, but we have compiled it from numerous sources as well as from the students' feedback that we have got from the recall session. So this is the best possible framing of questions that we have got for the subject of cons and endo for this year. So the first question is displayed onto the screens is: a patient underwent ceramic restoration. The clinician wants to finish and polish it. What is the sequence of this? The option A is apply overglaze or natural glaze before contouring and finishing. Apply overglaze or natural glaze before contouring, finishing, and polishing. Option C is apply overglaze or natural glaze after contouring, finishing, and polishing. And the option D was apply the overglaze or natural glaze after contouring. See, if you just do not look at the confusing words like applying the overglaze or natural glaze, simply we talk about the glaze of the ceramics. Then when we discuss ceramics in the class also, we have seen that ceramics should be having a highly glazed surface, and once a ceramic prosthesis is there and it is delivered, it should be delivered in the fully glazed state. There should be no grinding or removal of the glaze layer that reduces the strength of the porcelain markley. So if we look at that, then applying the glaze or the natural overglaze should be the final step. There are principally three steps. Whenever the prosthesis is made, it is contoured. So the first step would be contouring. This is step number 1. The second step is finishing. The third step is polishing. And the fourth step is applying the natural glaze or the overglaze. So what would be the sequence? 1, 2, 3, and 4. So option C, apply the overglaze and natural glaze after contouring, finishing, and polishing would be the answer over here. Whatever finishing, polishing, contouring, etc. is required for the ceramics has to be done before the application of the glaze. And once the glaze is done, no adjustment is permitted, because if we remove the glaze layer, which is about 50 micron thick, it would reduce the transverse strength of porcelain to about 50%. So option C would be the answer. Coming over to question number 2. See this, whenever we, just before the exams, when I was taking the predictor series, I told you that the questions like traumatology are one of the favorites for the NEET as well as other examinations, and they would give you a brief history of the patient regarding the age, etc., as to determine the status of the tooth. A similar question was there. A 15-year-old patient suffered traumatic injury 5 years back, means at the age of 10, I would say, the injury was there. Upper right central incisor, that is tooth number 11, it's talking about, is tender on percussion with IOP revealing an open apex. It is a blunderbuss tooth, open apex, with 3 millimeter diameter of the apical foramen. So it is a definite open apex tooth with thin dentinal walls, presence of periapical radiolucency. And negative response to pulp sensibility testing was recorded with not only maxillary right central incisor, but with the left central incisor as well as the right lateral incisor also. Mesiodance is present, which is not the correct treatment approach. So, if we look at the brief history of the patient given, some things are confusing that they started with 15-year-old patient, injury 5 years back, the effective age would be 10 years when the injury happened. The presence of absence of mesiodance is just for confusing. It has got no clinical significance. So there is a tooth, a maxillary central incisor with a periapical lesion, thin dentinal walls, and an open apex. This is basically tooth number 11 talking about. So when there is periapical lesion or periapical pathology means the entire pulp has degenerated. So what type of tooth is this? This becomes an immature pulpless tooth. Immature pulpless tooth. And what is the contemporary treatment for the immature pulpless tooth? Most recommended are regenerative endodontic procedures, REPs, pulp revascularization, pulp regeneration. So if we look at the options, epexogenesis of 1-1 is not possible because there is a periapical radiolucency, which indicates that the entire pulp has degenerated. No vital radicular pulp is available for attempting epexogenesis. Regenerative approach for this is definitely true because the diagnosis would be a tooth with immature pulpless status. Apexification can be done for this patient because it is an immature pulpless tooth. So the conventional treatment for such teeth has been apexification, whereby we form an apical plug, calcified plug of either MTA or calcium hydroxide. And surgical approaches are not required. So we are left with options B and C, and biologically based procedures like regenerative endodontic procedures, they are the most acceptable contemporary treatment for immature pulpless teeth. So the answer, most suitable answer would be option B to this question. Okay. Moving over to the next question, question number 3, another related to a brief history. And typically, this question belongs to the pedo, but anyways, it has been recalled in this session. So, a 4.5-year-old child presented to OPD with discolored 5-1. What is 5-1? Again, it is maxillary right central incisor, which is a deciduous tooth, 5-1. Okay, because quadrants are fixed 6, 7, and 8. These are the quadrants that we divide in deciduous dentition. The patient is asymptomatic with a history of trauma 6 months back. What is the treatment for this? So, asymptomatic tooth is there. A history of trauma is there 6 months back. Definitely, this would be a case of immature tooth. Okay. Again, with an open apex. But this is a primary tooth. Similar to the question seen above, this is a primary tooth. What would be the treatment? Since it is asymptomatic, we can render that there is vital radicular pulp. So what we have to attempt? In such cases, we have to attempt vital pulp therapy. Vital pulp therapy consists of direct and indirect pulp capping, okay, and pulpotomy. So direct and indirect pulp capping, DPC and IPC, they are ruled out for such cases because this is a trauma history 6 months back. Whenever the history of trauma is more than 48 hours, 48 to 72 hours, more than 48 to 72 hours, the inflammation of the pulp is deep seated and majority of the coronal pulp would be involved. It is only within the time frame of 48 to maximum 72 hours after trauma that the pulpal inflammation is superficial. We can attempt procedures like pulp capping, etc. Okay, so what we are left? We are left with the third option, that is pulpotomy. we would remove the entire coronal pulp and preserve the vitality of the radicular pulp so that there is continued root formation. So pulpotomy would be the answer over here, not IPC, not extraction, not pulpectomy. Pulpectomy is complete removal of the pulp. We will go with pulpotomy. Option B is the answer. Question number 4. The patient reported with complicated crown fracture. Another question from dental traumatology. The tooth is vital with open apex. The suggested treatment is. Okay, very similar questions. Couple of them have been asked related to open apex. Complicated crown fracture means there is involvement of enamel, there is involvement of dentine, and there is pulpal exposure. Enamel, dentine, and pulp, all three are involved. It becomes complicated crown fracture. So, fracture in a tooth with open apex involving the pulp. So, there will be a tooth, open apex. This is the pulp organ of the tooth, and something like this has happened. A fracture has happened that is involving the pulp of a immature tooth. What would be the treatment? Indirect pulp capping, pulpotomy, pulpectomy, or extraction? Okay. What would be the treatment over here? We have to promote apexogenesis. Whenever we have to promote apexogenesis, again vital pulp therapy would be done, and no time frame is given when did the trauma occur, whether it was a case of recent trauma or later trauma. I do not know whether exactly the same question had come or not, but this is what I got from the recall session. And since time is not mentioned, which is very crucial, the time between injury and the treatment rendered. So the best possible answer would be pulpotomy over here. We have to remove the red coronal pulp and preserve the vitality of the radicular pulp. Option B. If time has been given as less than 48 hours, then IPC could be considered. If at all time was mentioned over there, that was less than 48 hours. Pulpectomy and extraction definitely are not required. They are not the right options. So the most suitable answer would be pulpotomy. Why pulpotomy? Because we have to preserve the radicular pulp to induce root development and apical closure. Coming over to question number 5. While assisting for delivering an all ceramic restoration, the chairside assistant got accidentally exposed to HF. HF stands for hydrofluoric acid. What is the antidote? Now, this is a new question. I would say it has come, something like this has come for the very first time. And if at all you had a knowledge about this, then you would have been able to answer it. Means hydrofluoric acid, all of you must be knowing that it is used for etching of ceramic. We use 5 to 10% hydrofluoric acid for 2 to 5 minutes for etching of the ceramic. And what type of ceramics are etched? The feldspathic porcelains, okay, and your glass ceramics. The aluminous porcelains and zirconia ceramics, they are not etchable. So hydrofluoric acid, the patient assistant is exposed. Hydrofluoric acid can cause tissue burns, and an antidote for that is calcium gluconate gel in the concentration of 2.5% to 10% calcium gluconate gel is given. So this was a new question, and the answer would be option D. The antidote for hydrofluoric acid burns is calcium gluconate gel in the concentration of 2.5 to 10%. Okay. Coming over to question number 6. Following bleaching, there is compromised addition and polymerization of composite due to the following can be used to ensure adequate bond strength. Now, if you remember when I taught about bleaching, I told you that after bleaching of the tooth structure, the bonding of composites is compromised because of the residual oxygen ions present over there. They do not help. They would hydrolyze the covalent bonds that formed with the tooth structure. So Ideally and optimally, we have to wait for about 2 weeks or 2 to 3 weeks after bleaching for doing bonded restorations. If immediate is required, we can remove the residual oxygen and hydrogen peroxide by various agents like 3% catalase, alpha tocopherol, ascorbic acid, okay, etc. These are some of the agents that are used for the removal of residual hydrogen peroxide and oxygen ions from the tooth structure to provide good bonding with the placement of composites. So if we look at the options, sodium ascorbate, citric acid, EDTA, and sodium bicarbonate, answer would be sodium ascorbate, that is option A. Apart from this, what we can use alpha tocopherol, and 3% catalase can be used for this. 3% catalase solution is used for nearly 3 minutes to neutralize the residual hydrogen peroxide from the tooth structure. Okay, so answer would be option A. I would say a simple and straightforward question it was. Another related with a short patient history, a 59-year-old male patient is advised to undergo root canal treatment. He is on aspirin 75 milligrams per day for stable angio. It should be angina, stable angina, not angio. What is advised for such patients before undergoing root canal treatment? A patient who is on aspirin therapy, long-term aspirin therapy, low-dose aspirin therapy per day to manage the stable angina. Stop the aspirin for 3 to 4 days prior. Stop aspirin 4 to 7 days prior. No need to stop aspirin or stop aspirin 7 to 10 days prior. See, to answer such questions, we should be knowing the recent recommendations of the American Heart Association. And moreover, root canal treatment does not involve significant bleeding. Okay, there may be bleeding whenever pulp is amputated or pulpectomy is done, but that is not copious or significant. Even if minor dental procedures like extraction or I would say root canal therapy is considered, then the benefit of continuing with the aspirin is more than the risk associated with, I would say, the stopping of aspirin. So, in such cases, the American Heart Association says that there is no need to stop the aspirin therapy for such patients. So, option C would be the best possible answer over here. Definitely for major surgical procedures like periapical surgery or difficult transalveolar extractions, etc., there would be a need to stop the aspirin therapy about 4 to 7 days prior to the surgery. But for root canal treatment, no such alteration in the routine medical regimen is required, and the answer would be option C. There is no need to stop aspirin and we can continue with the root canal treatment. Coming over to question number 8. What is the difference between adsorption and absorption? Not specifically related to endo, but adsorption deals with solids and liquids. Absorption deals with gases. No. Adsorption is a surface phenomena, whereas absorption refers to diffusion of a substance within the body of the substrate. Adsorption is related to surface texture and absorption is related to surface energy. These were the three options that were given to me by the recall session. And according to the best, adsorption means it is the surface attachment of certain chemicals or gases onto a particular surface. Just like if we talk about direct filling gold. Direct filling gold is made non-cohesive by adsorbing 18% ammonium chloride onto the surface to make it non-cohesive so that the increments of gold do not stick together during storage. So adsorption is basically a surface phenomenon, and something that is absorbed means we would say that absorption of certain chemicals from the food that we take, absorption of nutrients from the food substances occur in the intestine like that. So the absorption refers to diffusion of substance into the body of the substrate. So option B would be the answer over here. A relatively simple and straightforward question with the straightforward options. Moving over to the next question, question number 9. A male patient reported to clinic having heavy occlusion. He is presented with wedge-shaped defect on the cervical areas of facial surfaces of maxillary premolars. What is the diagnosis? Heavy occlusion with wedge-shaped defect. So heavy eccentric occlusal contacts result to idiopathic erosion. These are cervical defects, non-carious cervical lesions called abfraction lesions. Due to heavy eccentric occlusal forces, abfraction is also called idiopathic erosion. Due to heavy eccentric occlusal forces, the tooth flexes in the cervical area and there is fracture of the tooth structure in the cervical area that leads to non-carious cervical lesions called abfraction lesions. So options are abfraction, erosion, abrasion, and GERD. GERD is a gastroesophageal reflux disease. Answer would be option A, that is abfraction. In our classes also, we have seen that for abfraction lesions, which are a type of non-carious cervical lesions, the restorative material of choice are microfilled composites. These microfilled composites, they have low gamma. Gamma is the modulus of elasticity because they are flexible materials. So when the tooth flexes in the cervical region with heavy eccentric occlusal forces, these low modulus materials like microfilled composites will also flex with the tooth structure and they would not become debonded from the tooth structure. So these are the different sets of questions that have been asked. What are the restorative material of choice for abfraction lesions? Now, what is the property of restorative material to be used for abfraction lesions and what are abfraction lesions? So option A is the answer for question number 9. Question number 10. Which of the following is caries promoting? Now, this is, I would say, a straight pick from your oral pathology like the Schaeffer's. If you have read that book, then caries, you can remember that the influence of caries by certain microelements, selenium upon vanadium. So vanadium inhibits caries, selenium promotes caries. So options vanadium, lead, selenium, and molybdenum. You may get confused with lead because lead also to an extent promotes caries, but more specifically selenium is implicated in promoting caries. So answer to this question would be option C. Another simple question. Coming over to question number 11. A composite restoration was done in maxillary anterior tooth. Okay. It was decided to polish it with bonded abrasives. Which of the following is the strongest bonded abrasive? Now, actually speaking, the question could have started from here only. Which of the following is the strongest bonded abrasive? Okay. Means this is a question related to finishing and polishing materials. And the above two sentences like the composite restoration was done and it was decided to polish were just given to confuse you a little bit. Which is the strongest bonded abrasive? Bonded abrasive are of 4 types from the knowledge of your finishing and polishing materials. They are the sintered materials. Sintered means the materials are fused at high temperature to form a tough bonding material that is used for finishing and polishing. Then there are rubber based. Then there are vitreous materials which are glass or ceramic based. And then there are resin based bonded abrasive. The question is asking which is the strongest bonded abrasive. For that, you should have knowledge that sintered ones, they are the strongest bonded abrasive systems for finishing and polishing. Options rubber, resin, sintered, and vitreous. Option C would be the answer. Another straight question with a straight answer to it. Coming over to question number 12. The following restoration, it was decided to do truing and dressing of the abrasive instrument. Which of the following represents the dressing procedure? Now I am surprised to see a couple of questions from finishing, polishing, a direct pick from your dental materials. Okay. What are the terms truing and dressing? See, there are different abrasive materials. Truing. Truing means if there is a abrasive point like a green stone or a white stone, there is a point of abrasive point. Before doing any finishing and polishing, that abrasive point is first run against a very hard abrasive substance. Okay. What it does, it is done to check the concentricity or eliminate any eccentricity or run out of the material. Means there is a point that would be placed in a micromotor or any other suitable device. It would be rotated for doing finishing and polishing of the restorative material. So before attempting to do finishing and polishing, we have to do truing of the material. What is truing? Truing means it should rotate without wobble on its axis, should have very less run out. What is run out? You know already. Eccentricity or run out is deviation from a single point when the instrument is rotated. So to eliminate any run out or eccentricity, it is first run against a hard substance, tested, so that to see whether it is having exactly same concentricity or not. Okay. And what is dressing? Dressing has two steps are there. The first step of dressing means we have to reduce the dimensions of abrasive material. Whatever abrasive material is there, it is in the shape of a cylinder, it is in the shape of a cone. Okay. According to your finishing and polishing requirements, we have to reduce the size of this finishing and polishing material. It is called dressing. And second is to remove clogged particles. Okay. They are coarse materials. So whenever we use them to finish and polish the materials, the spaces between the pores, they are clogged with that material that we are finishing and polishing, or debris is generated that clogs the pores and makes it less efficient. So dressing is achieving two functions. Firstly, it is reducing the dimension, size and shape. And secondly, it is unclogging the spaces between the abrasive particles. So let us see the options. It removes the clogged particles, is true. It is asking about the dressing procedure. It promotes blinding, no. Prevents eccentricity and run out of the rotating instrument. What prevents eccentricity and run out? Truing and not dressing. So option C is also ruled out. Enlarges the working size and shape? No. It reduces the working size and shape. Dressing reduces the working size and shape. So answer would be option A to this question. Okay. I hope now you have understood truing and dressing. Interesting questions, relatively new questions, never have come before. But if you have read finishing and polishing materials, you would have been able to answer this. Question number 13, I would say another question directly lifted from whatever I've taught you in the notes. Cusp capping is considered when the outline form extends more than two-thirds the distance from the primary groove to the cusp tip, extends one half to two-thirds the distance from the primary groove to the cusp tip, half the distance from the primary groove to the cusp tip, or two-thirds the distance from the secondary groove to the cusp tip. Now, if you remember when I taught about fundamentals of tooth preparation for dental amalgam, etc., we saw that we, for capping of cusp, there is a rule that we measure from the primary groove to the respective cusp tip. If the distance is less than one half, there is no cusp capping is done. When the distance is one half to one half to two-third, extent of caries from the primary groove to the cusp tip. This distance is suppose x. Okay. It is between one half to two-third. We consider cusp capping. And when it is more than two-third the distance, we always cap cusp. Or we can say it is recommended. So what is meant by considering? We would consider the cusp capping when the extent of caries from the primary groove to the respective cusp tip is between one half to two-thirds the distance. Consider means we would cap the centric holding or the stem cusp, which are the palatal cusp of the maxillary and the buccal cusp of the mandibular, and we will not cap the non-supporting or non-centric holding cusp. So the question is asking cusp capping is considered. It is considered when it extends one half to two-thirds the distance from the groove to the cusp tip. Option B. Okay. Coming over to the question number 14. The resistance to cutting of enamel with bladed hand cutting instruments is seen with prismless enamel, cervical enamel, regular enamel, or gnarled enamel. Okay. Means resistance to cutting with hand cutting instruments like chisels, enamel hatchet, okay, gingival marginal trimmer, okay. These are all what? Hand cutting instruments. So when you feel resistance, cervical enamel, no. With the regular enamel, no. You're left with options A and D, prismless enamel and gnarled enamel. Prismless enamel is the outer enamel that is very hard and it is resistant to cutting with the hand cutting instruments. So answer would be option A. Prismless enamel is the outermost enamel, structureless enamel that covers the surface of the crowns. It is very resistant or hard to the action of hand cutting instruments. Question number 15. Clinically, how to differentiate between white spot lesions of early caries versus those of hypoplastic lesion? A very simple question. White spot lesion of early caries, they would disappear upon hydration of the tooth and they would appear when the tooth structure is dehydrated. On the other hand, hypoplastic lesions are visible irrespective of the state of hydration. Okay, so white spot lesions disappear on hydration, whereas white spot lesions of hypoplastic lesions are not affected by drying or wetting with water. I do not know what were the options B, C, and D. They may be the reverse, but this is the answer to this. White spot lesions of caries, okay, they disappear on hydration. Hydration means whenever we wet the tooth structure. And whereas the white spot hypoplastic lesions are not affected by drying or wetting with water, would be the answer. Question number 16. A 9-year-old child fell in the park and this led to avulsion of upper left central incisor, another related to trauma. His mother should keep the tooth immersed in which of the following before reaching the clinic? There's a case of avulsion. So it is basically asking about the most suitable tooth storage media. Saliva, saline, milk, and tap water were in the options. Out of the options given, we know that milk is the most suitable option. If we talk about the sequence, then wire span, Hank's balanced salt solution, cold low fat milk, the patient's own saliva, saline, and tap water. This would be the sequence from most preferred to least preferred. Most preferred to least preferred what? Tooth storage media. So if we look at this sequence, then the cold low fat milk is the most suitable for this, followed by saliva, saline, and tap water. So milk, option C would be the answer. At times they've asked about the fat content of the milk, then it would be a low fat milk. They have asked about the temperature of the milk, it would be a cold low fat milk. Question number 17. Clinician realizes that his addition silicone material is not setting properly. Upon investigation, he finds that the assistant is using latex gloves to handle the material, which is true. All of you must be knowing that the sulfur content of the latex impairs the polymerization of your addition silicone materials. That's why the use of latex is contraindicated with addition silicone materials. Hydroxyl ions are being released and they are hampering the reaction of the base paste. No. Sulfur is released from the gloves, acting as a poison to platinum, which is a catalyst in addition silicone material, slowing the reaction. True. Water powder ratio is hampered, not related. So option B would be the answer over here. A straightforward, simple question. Coming over to question number 18. The disadvantage of using ultrasonics to perform root and preparation. If you remember when I taught about periapical surgery, it saw that there can be three methods of root and preparation. One is your burr with a handpiece, another is ultrasonic, and the third one is laser assisted preparation. With ultrasonic, what is the disadvantage? It can cause microfractures on the root surface. We have seen that there can be three types of fractures: intracanal fractures, okay, extracanal fracture, and there can be a communicating fracture. Intracanal means the fracture would originate from the root canal, extend outward. Vice versa, the fracture would originate from the external tooth surface, move inward, and there can be a through and through fracture. So, microfractures of the root surface is the answer to this disadvantage of using ultrasonics for root and perforation. Coming over to question number 19. A class 2 restoration was done on maxillary first premolar. Mesoocclusal class 2 restoration was given. It has a cervical overhang. What is the reason for this? The mesial marginal or developmental groove, canine eminence or fossa, or stippling. See, if we look at the surface of maxillary first premolar in a cross section, it is somewhat kidney bean shape. The mesial side, the distal side, the buccal, and the palatal side, the maxillary first premolar is a characteristic. So whenever we do class 2 restoration, like ammo restoration is being done, okay, if the matrix band is applied with a wedge and it is not pressing against it, the method of wedging that we use is wedge wedging. We use two wedges instead of one, and the method is called wedge wedging to adapt the matrix band closely to the mesial concavity of the root surface. So there would be a mesial overhang because the matrix band is not properly adapted to the concavity because of improper wedging. So what is the reason for this? It would be mesial marginal developmental groove, which is characteristic anatomic feature of maxillary first premolars. Answer option A. Okay. Question number 20. The referred pain is carried by which nerve fibers? I think there should have been no difficulty in answering this. A delta, A gamma, A beta, or C fibers. It would be C fibers, option D. Sorry, option D. C fibers. Referred pain. Referred pain is basically pain felt in an area which is supplied by a different nerve than the primary source of pain. Okay. So, whenever there is tissue injury, true form of deep-seated tissue injury, okay, these pain would be referred through C fibers. Two type of sensory fibers you have to remember. They are the A fibers and the C fibers. A fibers, they are causing short and sharp pain. C fibers cause dull throbbing and a longer lasting pain. So referred pain is carried by the C fibers. Option D would be the answer. Question number 21. Thermoplasticized obturation technique is contraindicated in another relatively simple question. Thermoplasticized obturation means injection of liquid gattaparcha inside the root canals. When would you not use this technique? In cases of open apex, in cases of internal resorption, or C-shape anatomy for backfilling of the root canals. Backfilling means if this is a root canal, apical 1/3 is obturated with gattaparcha, and then we fill thermoplasticized gattaparcha into the root canal. This is called backfilling. So it is indicated for backfilling, for C-shape anatomy, and for internal resorption, but not for open apex, because if we inject liquid gattaparcha in a tooth with open apex, the gattaparcha would flow out from the tooth into the periapical tissues, because the length control with thermoplasticized gattaparcha is not good. Option A would be the answer. If you go with the method of exclusion, you would have been able to arrive at this answer. Question 21, option A would be the answer. These were the questions that I got related to my subject, and I would say out of these 21 questions, hardly 2 or 3 of them, at max 3 questions, were related to those finishing and polishing. They were a little tricky, otherwise majority were very simple and straightforward. You must have done well. So this is all about the recall section. Thank you very much for being connected with me. Okay, see you in the next section.